Good afternoon from Frankfurt, Germany. Thank you very much for the kind invitation. Unfortunately, I could not attend this year because I'm attending CSI. I will do this lecture in English because I believe there are maybe some international participants in the meeting. We will talk about the need for left lateral appendage occlusion and particularly the patient selection. And these are my disclosures. We are in the decade of stroke, hopefully stroke reduction. Stroke is a major socioeconomic problem and it affects patients worldwide. It's a big problem. And more specifically, the cardioembolic stroke is another subgroup of stroke, which is very, very important because it has higher morbidity and mortality. These slides you will see at the end, these are potential indications for left lateral appendage occlusion. But before going there, I will start with this anatomical structure per se, which is the reservoir for thrombus formation in patients with atrial fibrillation. You can see here, this is a transesophageal echocardiogram by a patient who is under general anesthesia. His blood pressure is 90 to 60 and his heart rate is 60. These are sleeping conditions, okay? We have this hemodynamics when we are sleeping, when we're asleep, and this is what happens. This is a dynamic situation in the left atrium and in the left atrial appendage, as you see here. When we give inotropes and the blood pressure increases and the heart rate is higher, then we have a totally different scenario. I put this video here because it shows that this is not black or white. The thrombus formation is something that it may be continuously changing, and we do not always capture all the details. The anticoagulants started as rat killers. It can be poisonous, and no matter how much they helped in the stroke prevention, I think we may have reached a limit in their use. We talk about p-values and risk reduction, and we're happy when we have small improvements in our results. However, there is an elephant in the room, and the elephant is called adherence. The patients do not want to take this medication, and we can see that from data when we introduced in clinical practice years ago the non-vitamin K anticoagulants. It did increase the adherence somehow, and but it did not increase it substantially. Less than 50% of the patients are treated according to the guidelines. This is a huge patient population. Even and this is true for all the anticoagulants, all the new anticoagulants. And the main reason for that is that these drugs are associated with a major bleeding risk of 5 to 7% per year. So the introduction of the anti-11 factors has been promising at the beginning. However, it looks like the drugs are safer, they have less bleedings, but they seem to be not so effective. So, for example, this trial was stopped 2 years ago. Now, the proof of concept for left lateral appendage occlusion were given by the surgeons in this very nicely conducted randomized clinical trial when they compared surgery alone versus surgery plus LA closure. And the study was very clearly positive in favor of left atrial appendage excision in particular, when a patient undergoes surgery. However, there is a lack of data in the percutaneous LA closure. And this is true, meaning that we have this nice result by PROTECT AF when we show reduction in all-cause mortality in 4 years. However, we do not have big trials comparing LA closure with NOACs, with the exception of PRAC 17, which was a small study. This has changed, and I will show you 1 or 2 items about it. What has been very disappointing is that in the ESC guidelines, the LA closure, the percutaneous LA closure was still in 2B indication. Whereas in the American guidelines, it has increased from a 2B to 2A indication. And there is a discrepancy between the European and the American guidelines, and this creates quite a lot of confusion. We are trying to solve that. Now, in this consensus paper that we published years ago, we were saying that patients that are suitable for for oral coagulation should receive it, and others should be discussed. 7 years ago, we conducted this study that was published in a European Heart Journal. It's called MISO-AKF, and this shows potential indications for LA closure, but it shows also another important thing, that when you do an intervention, and these are a study that was conducted in Greece in 1,000 patients randomized, and we did an intervention on the half of the patients, trying to increase the adherence. The positive effect of this was when we increased the adherence to 77%. So that was the top. Whereas the adherence, when you do a procedure, an LA closure in particular, is 100%. There is no issue. So this should be taken into account when we're discussing an intervention as compared to drug therapy. Now, the main indication for LA closure in this sub-study that we did from the MISO-AKF were intracranial bleeding or gastrointestinal bleeding on patients who had an embolic stroke while on adequate anticoagulation, and these were considered stroke indications. And we had a loose indication, the end-stage renal disease or just a Hess-Bled score, and we didn't even put in the equation the adherence. And you can see here that 1 out of 3 or almost patients who were hospitalized with atrial fibrillation in a Greek hospital for any reason were potentially eligible. And 70% to 80% of these 1,000 patients had a strong indication. And you can see here what were the main indications. It was prior major bleeding, the stroke on anticoagulation. These were the strong indications. These were the more loose indications. And we also had the poor adherence with almost half of the patients. Now, from the patients that were eligible, most of patients had an upper or lower GI bleeding. So in this particular group, we need to make sure that there is no correctable cause of bleeding. If there is no correctable cause of bleeding, then we have a strong indication for LA closure. In every subgroup, in this study that we published almost 10 years ago, and since this was a physician-initiated study, we tried to investigate these subgroups. And I will just briefly show you studies that we did, subgroup analysis for each particular indication. And these were the general results. We had the 60% stroke reduction and a 60% bleeding reduction as compared to the events that we would have predicted by the Tsiapras score and the Hess-Bled score. Now, in the patients with intracranial bleeding, we had 200 patients with previous intracranial bleeding. The results were even better, probably because we were giving only aspirin for the short period after the procedure, which had no real effect in the bleeding in these patients. The stroke severity after left atrial appendage occlusion is also very important. The few strokes that we have seen in this sub-study were mostly non-disabling. More than 80% of strokes were non-disabling, and this is a very important message for the patients. In patients with chronic kidney disease, we did a sub-study, and we found that they had similar procedural safety, and they still had a dramatic reduction of both stroke, TIA, and bleeding. And in the patients with the resistant stroke, the stroke on anticoagulation, which had similar results from the ACP registry, no matter what why the patients were sicker and had higher Tsiapras score, the reduction and the achievement that we had with LA closure was similar to the rest. There are several randomized clinical trials happening. There is a nice review that we wrote recently. You may refer to that to the European Heart Journal, where you can see the studies that have been conducted and the studies that are in progress. You see that we have many studies in progress. The option trial was published recently, and this is what I will briefly present to you. And the top study that we're expecting soon is the Champion AF study. This will be completed in February next year. and this may change completely the field of stroke prevention. So this study compares LA closure with Watchman to NOACs in all comers. It means that we have every potential candidate who has a Chatzitofi score of more than 2 or more is a candidate. No issues with previous bleeding. There is a similar study conducted by Abbott, the Catalyst study. This is a little delayed, but it has a similar patient profile, and we hope we'll see the results soon. The closure EF is supposed to be presented in ESC in Madrid 2 months later, but we're not sure if this is going to happen or it will wait for November. And the option trial, this is already published. It showed some substantial findings published in the New England Journal of Medicine. This is a comparison between ablation plus Watchman versus ablation plus oral anticoagulation. And in half of the cases, 60% of the cases, the two procedures were performed sequential, and in 40% they were performed in the same session. And there was a non-inferiority for the device versus the drug in this group of patients in stroke prevention. And at the same time, we have a very strong stroke reduction for both groups, 1.2% in 3 years. This is a very strong message, means 0.4 per year. And there was the superiority endpoint was met with respect to bleeding. So the patients who underwent the procedure and had a Watchman device, they didn't have bleeding at follow-up or much less bleeding. And even if you included the peri-procedural bleedings. So this was a very important message, and I will finish with this practical guide on LA closure. Just to go back on the indications. You see here patients with recurrent major bleeding that cannot be corrected, patients with low adherence to anticoagulants, patients with ischemic stroke despite oral anticoagulation, patients with intracranial hemorrhage, or patients in which we want to avoid triple therapy after coronary stenting, patients with deep LA left atrial appendage thrombus, or the ones that have been isolated with ablation, or patients with renal failure and hemodialysis. These are all potential candidates for LA closure, and we're hoping to send the elephant from the room to vacation to take the adherence out of the equation. Thank you very much.
So this was a very nice talk, as we expected, from Dr. Tzikas. So any comments from the audience? Vaso?
One point is the selection of the patient. Yes. One point is the selection of the appropriate candidates for the LAAO. The other point is the new devices that are coming. And a question is about the device-related thrombosis.
Good. Yes. So the patient selection, it's an interesting thing, and it's there is some let's say peculiarity in the Greek numbers. The LAAO procedures are very low, much lower compared to the other Western Europe. So maybe in Greece, multidisciplinary teams are not communicating properly, and I don't know, maybe it's we need to talk to a radiologist or neurologist, but most importantly to convince other cardiologists which are not convinced that LAAO is a worthwhile procedure. And this is very interesting. And now I have a live in a box after this theoretical talk, and Dr. Chatzitofi.